We okay to get started? We all good? Cool. You all good, guys? Yeah. Cool. Just coming in. I'll just wait for these people to come in and then we'll get started. So I'm actually really surprised this many people came out. I was expecting you all to just like go have lunch and then go home, but great turnout. It's Clin Skills, so I'm going to be not only giving you some tips and advice for the CSSEs, which are coming up pretty soon for you guys, is it next week? But also there are going to be clinical skills questions in your exam. So we're going to have a bit of a talk about that as well. So I'm not going to go on too much. I'm not going to go through every single examination, everything that you have to do, because it takes hours and hours to learn. You guys have done hours and hours worth of Clin Skills tutes. It's a waste of time. So all we're going to do is talk about the most important things, and we'll get through them when we get to it, and you'll see what I mean. But yeah, so I'm Kate, for anyone who didn't know. Cool. So this is a general overview I'm going to follow today. So we're going to start with history taking. I'm going to touch briefly on presentification, and we'll have a bit of a chat about why that might be important. Then we're going to do the physical exams. I'll finish with motivational interviewing and giving an explanation. As far as I'm aware, you guys won't have to do either of the bottom two for your CSSEs coming up. I don't think you will, but it's a really important skill to keep a track of, because starting from early on in Sem 1 of next year, you'll have to know how to do these things. Cool. So CSSEs, just a general bit of advice. Show up on time, but be prepared to wait. There have been times where our CSSEs have gone late for 2 hours. They've been running behind. So it gets real boring. So bring a book or practice with your friends, do stuff like that. You need to dress appropriately, because Nadita will cut you and she will send you home. I am all for girls wearing whatever they want to wear, and you look fantastic. Nadita doesn't agree with me. So I think you look fantastic, but I don't think it's really worth getting sent home. So I've even had a friend who was wearing a V-cut top, and when she leant down to do a cardio exam, it was kind of looser and it showed her cleavage, apparently, in Nadita, and Nadita told her off for it. So, and if you're going to use a tie clip for wearing a tie to prevent infection control, because you're leaning over someone and your tie is touching them. You guys probably won't wear ties, but, you know, whatever. Yeah, and you get 15 minutes in the CSSE as far as I'm aware, so make the most of it. You really want to demonstrate all your systems review knowledge. You want to delve into that essence social history, because you'll never get to do it again. And you really want to establish your rapport, because that's where a large amount of your points come from. And try not to cheat. I know it's really tempting because they don't sequester you for the CSSEs. Someone will come out from a morning session, you'll be like, "Oi, what was it?" And they'll be like, "It was cardio and like musculoskeletal history." And you're like, "Lit, I'm just going to study that from the book." Try not to, because you're not really doing yourself justice by cheating, and you don't actually know your level. You'll come out and be like, "I was great at that," but were you actually? So yeah, anyway. So this is an example of a type of clinical skills question. So this is a year 2 question, so I don't expect you to know the answer, but it kind of integrates anatomy and clinical skills and physiology into what you would see. So it's actually really important to know what's behind what you're testing in your examination. So why are we doing this special test? What's it testing for, and what's the relevance? So I'd be really impressed if any of you knew the answer to this. Does anyone have an idea? It's C. Does anyone know what? Did anyone get that right? Did anyone get it right? Did someone? No, just guessed? Okay. But yeah, you'll learn all about that in first sem next year. So you don't have to know anything like this. It'll be at your level, but that's the kind of question it'll be. Cool. So we'll just start off with history taking. So obviously it's going to follow this format. You guys have done this to death. I'm not going to go through it a million times, but this is the kind of way you want to be looking at it. Remember ATSE status. A lot of people forget it. Really important, easy way to get extra marks. Your history of present complaint, I split up BICE and WWQQA because people forget about BICE. You'd be so surprised about how many people, and there's a mark for it. So what are you concerned about? It's a really, really easy mark. And if you forget it, because it's a little letter in an acronym, you will lose a mark. Systems review. Do your relevant system, obviously the main important part, and then a couple from another system just to show that you're checking all your bases and that you also know another system. So you're not just knowing the MSK, you also know a bit of PNS. So it really shows the examiner your knowledge. Another one is the 5 systemic questions. You need to ask this every single time. So often forgotten, really, really easy marks, really, really important. And then the past medical history, family medical history, medication, social, you go through that. Cool. So I have a little bit of a thing about mnemonics. So they are the fast way to remember stuff. They're the easy way to remember stuff, and they're fine for this CSSE level where you guys just have to rattle off a list. You get tick, 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 tick for every single one you remember. But mnemonics can be really difficult. Yeah?
What are the 5 systemic?
I'll go through that. Yeah, you'll see. So mnemonics can be really confusing, especially the longer they get. You're like, oh God, what does it stand for? I don't even know. Then you forget the mnemonic and then you freak out. You pause, you go, you sit there spending 10 seconds wasting your time in a CSSE or in an OSCE trying to remember the mnemonic. They're often also out of logical order about what makes sense for asking the history. They don't really indicate your understanding, and they'll notice that people will ask the same order questions every time. And they'll be like, this person doesn't know what they're asking. They're just rattling off a mnemonic. And also you run the risk of re-asking your patient's presenting complaint. So for example, the mnemonic for cardio, if they've come in with palpitations, which is towards the end of it, and then you go, oh, so you had an edema? No. Do you have any palpitations? Oh, wait, hang on. I've already asked that. That was why you came in. So you look like an idiot because you weren't thinking. Yeah. So pro tip, don't re-ask. So I prefer to go with, this is what I have for my systems review for everything in year 2. You guys obviously are only doing 1, 2, 3, this corner here, but I don't have mnemonics. I've got them chunked, and I'll go through how I chunk them, but I also have the mnemonics for people who really do find mnemonics work for them. So it's up to you, however you remember it, but I've got both for everyone. Cool. So we'll start with MSK. I chunk them like this. So I've got describing the injury or the problem, and then how the problem impacts you. So pain, swelling, deformity, weakness, and instability are like, how would you describe the adjectives of what the problem is? And then the joint stiffness, morning stiffness, loss of motion, loss of function, changes in sensations, how that is impacting your overall functioning. So I chunk them like that. Another way I think about it is the 1-word questions and then the 2 or more word questions. Cool. So that's your systems review there. Another way that people use the mnemonic would be pills with D-Day Sam Chung. I don't know who Sam Chung is. I think he was an older student, but whatever. So yeah, you'll notice that it ticks off everything in the box. What's weird about it is systemic features come before changes in sensation, which I don't like. And also they're kind of out of order and it misses out morning stiffness. You have to remember that joint stiffness comes in with morning stiffness. But if this works for you and you've done really, really well using this mnemonic, go for it. Whatever you want. Cool. Neurosystems. I chunk it really weirdly, but I think it'll make sense when I describe it. So I start off with central nervous system problems. So headaches, vertigo, fits, and faints. They are all like cerebral problems that are happening inside your brain. Makes sense. The next 3, weakness, paresthesia, anesthesia, they're all peripheral nervous system problems. So below the level of probably like brainstem. The next 3 are control issues, so gait problems, involuntary movements, anything from tremor to hemipalismus, and sphincter control. They're all going to be spinal cord problems and probably cerebellar problems as well. Then the next kind of 5 here, they're a bit weird. They're kind of like the senses, but they're all cranial nerve problems. So vision, smell, hearing, speech, swallowing. So there'll be the nerves coming out of your brainstem that are supplying your face and your head and stuff like that. The next 3 are my concussion questions. So have you had a head injury? And if you did you lose consciousness? Altered cognition is hard to question, really. It's kind of, you kind of just perceive that from the way they're talking. But you might ask, like, have you had any memory problems recently? And then the last one, back pain. If you've fallen and hit your back, you might have a spinal injury. So these are my concussion questions. And then the last 2 are the infectious questions, neck stiffness, photophobia, nausea, vomiting. Really, really important things to watch out for, things like meningitis and encephalitis. So if you ask these questions in these chunks, the assessor really knows clearly what you're asking for. Because if I do it in mnemonic and it's all kind of cut up, I'm ticking off the boxes. But if I ask, have you had any neck stiffness and photophobia, and have you been feeling sick or vomiting recently? They're like, okay, that person's really clearly asking for meningitis or encephalitis questions. If I ask about head injury and back pain together, they're like, I know this person's asking about concussion. It kind of makes sense that way. It may be a bit harder for some people that way, but it really works well for me. The head swing mnemonic also works, and as you'll see, you'll tick off everything. This is all the criteria. I went through your Clin Skills book and made sure. But as you'll see, there are like 2 in the same line or like 3 in the same line, and sometimes like there's one word that means 2 different things. But I mean, if it works for you, there might be another one also, pads versus wings or something like that you guys use. I don't know, but this one is one I found. Cool. So yeah. Cardiosystems is the only one I do use a mnemonic for because it's 7 questions. So it's that easy and they kind of make sense. So I use 3D COPS. I think there's another one out there, but I use this one. So the 3D is the 3 dyspneas, so exertional, orthopnea, and paroxysmal nocturnal. And then I have chest pain, edema, and claudication are chunked together because they're both legs. So when you're asking about edema, it makes sense to also ask about claudication because they're both calves. And then palpitations and syncope. You'll notice I've left off fatigue at the bottom of this one because 5 systemic questions, you start off with fatigue. So it doesn't really matter what one you include it with, because at the end of the day, you're going to be asking them directly on from each other and the assessor won't know the difference. So yeah, your 5 systemic questions, ask them every single time. They're really, really, really important. So you're going to ask for fatigue, malaise. And when I say malaise, I don't mean like, are you feeling kind of bad now? It's more like, have you been feeling under the weather recently? And then you're going to want to ask about fever, night sweats, and weight loss. And we know that the last 2 are mainly for cancer and tuberculosis and stuff like that, which is not really going to pop up, but yeah, worthwhile. Cool. So then we're going to go on to past histories. You guys know this quite well, but I think what a lot of people, you can get extra marks, especially in CSSEs when you have more time, by saying the ABCDs. So you say, do you have any medical conditions? They go, nah, none that I can think of. And you go, okay, do you have asthma? And they go, oh yeah, I do. Forgot about that. So it happens all the time. It's happened to me so many times on real placements. I'm not joking. Same with blood pressure. They kind of think of it less as like a disease and more of like, it's just a part of who I am. I just have high blood pressure. That's just me. And then asking about recent illnesses and recent infections over the past month or 2 can actually be really important. Does anyone have any examples about why that might be? Why would a recent infection or virus be important for any of these systems at all? Does anyone know? It is. So what if I said someone had an ear infection recently and then they come in with a bit of a sore neck and they've been feeling pretty sick and they've vomited a couple of times. What are we thinking? Meningitis. Good, exactly. Things like that. Or someone has a bit of an older person. They had the flu, but they were okay because they did have their flu shot. But they've had a really sore chest recently, and when they were getting changed, they noticed they've got this massive rash going across their rib cage. Or it might be wrong there. Shingles. Yeah. So the recent illness can either be the root cause of what's wrong with them now, or it could be why they've been under the weather and then an opportunistic infection has created what's wrong with them. Cool. And then obviously surgeries, hospitals, vaccination, you guys know that. Family history, how mum and dad, do you have any siblings and how are they? And then it might be worthwhile to ask specifically, do you have a family history of joint, muscle, bone problems? Do you have neuro problems in your family? Do you have heart problems? Because they might say, oh yeah, mum and dad are fine and siblings are fine, but oh yeah, all 4 of my grandparents died of heart attacks. So you're going to miss some critical information there if you forget to ask about extended family, especially grandparents and stuff. And there are things that can skip generations and it gets all very confusing with genetics. But yeah, worthwhile. Extra little question in there. Cool. Medication history. Please say medication history. Do not say drug history. Just, how does this sound? I'm going to ask you about your drug history now. Yeah, they're going to be like, oh my God, what the hell? But if you say, I'm just going to ask you a couple of questions about meds you're taking, they're like, yep, cool, chill. This is mnemonic is great and in order. I know they teach it in first year. They definitely teach the drugs mnemonic. So yeah, it's really, really, really good. So the important thing to remember is when you ask what they're taking, ask them what they're taking it for. Like, why are you taking that? How much are you taking? When are you taking it? Do you have any side effects? Because if someone comes in, it's probably more important for later systems, but if they come in with stomach pain and then you say, oh, do you take any over-the-counter meds? And they go, oh yeah, I just test some Nurofen from time to time. But you don't ask how much Nurofen they're taking. And they say, oh, I'm taking 8 tablets a day for the past 10 years. That's going to be the source of their stomach pain. So really important to ask that. With the recreational drugs, we ask this of everybody. It's a good little thing to make sure people don't feel like they're being targeted. A lot of older, especially if you've got actors, they'll be like, oh, how dare you ask this of me? Oh my God. But yeah, whatever. Gynecological system, drugs. Please ask this of women only. I'll put my hand up and say, I asked a man once if he took any hormone things like estrogen or anything. And in the end, the assessor was like, so question, why did you ask this male patient if he was taking any hormonal things? And I had to make up some kind of thing like, well, he could have been trans and I didn't want to like assume his gender. It's complete bullshit. So yeah, think through at that point, do I really need to ask if this person is taking the pill? Okay. Sensitivities, what happens? So there's a difference between, oh yeah, I get a rash and I die. So it's an important one to have. And then with alcohol, you guys know all about the cage questions and calculating your pack years. Really, really important. Sometimes if you forget alcohol and smoking, in the past, it used to be instant fail. Nowadays, it's not, but older examiners will look on you very poorly if you forget alcohol and smoking. Someone told me that recently. So it's definitely something to remember. And I kind of include it in drugs. A lot of people include it in social. Better to include it here because you'll remember it. So, I don't know how it works, kind of like drug czars or drug ass or something, I don't know. You can change it up if you want. Cool. And then social history. So at the top of this, ask about recent travel. Really, really important. Not so important now, definitely important next year. And then essence. Okay, essence sucks. I know it sucks. There are like 3 E's and 2 S's and I hate it. And you never use it again after CSSEs. Great news. But you have to know it now and just learn it. You got to do it like one more time for one more history taking. Just do it. You can forget about it after like October. You'll be right. Cool. So presenting a patient. This one is not super important, but I'll explain why it might be. Okay. So you are going to be repeating all the positive relevant information of what you've just heard. So today I saw John Smith, age 52. He's a truck driver and of non-Aboriginal Torres Strait Islander origin, who presented with 3 hours of chest pain. The history of this is the relevant stuff. The associated symptoms include palpitations and dyspnea. I don't know. Past medical history includes important stuff. Family history includes important stuff. To summarize what they are, and then older students would then give their DDX. This is not super important for you guys because you won't be presenting a patient. However, if you guys get 15 minutes to do a history, it's ages. We get 8 minutes. You can feasibly do a history within 10 or so, especially at first year level. So if you end up with a lot of extra time and you don't know what to do, it might be worthwhile saying to the patient, okay, so I'm just going to summarize what I've got back from you. Can you approve this information, make sure I've got everything correct? So you've come in with X time of this condition and you've also said you had this. And then you make sure that you took everything that the patient wants you to take in, and then they go, yeah, that's correct. And you go, okay, so I'll tell the doctor all this. And it makes you look like you've been listening, that you're competent, that you know what you're doing, you've summarized, so the patient feels involved. It's great. The assessor will be like, oh my God, she did a summary. It's so good. And the other great thing is get this now, and doctors in clinical years will love you because you have to start doing handovers in 3rd year. So if you're a boss at it from first, you're rolling. Cool. Physical exams. Okay. You've got to start off with the intro and consent. I know a lot of you are going to be tempted because you're going to be stressed and you're going to be short on time. You're going to go, hello, my name's Kate Griffiths. I'm a first-year medical student today. The doctor's asked me to come in and do an exam on you. It'll involve me taking doing a cardio exam, listening to your heart. You'll be required to take off your top. Is that okay with you? That's not good because you've got all your information out, but you're instantly going to lose 2 marks on how you talk with the patient, your communication with the patient, because that's a really important part of the exam criteria. It's, so take the time. You guys have got 15 minutes. Take the time to slowly, not too slowly, assertively, clearly say who you are, what you've come in for. Make sure the patient isn't like, what's happening? And there's like little legal ethical stuff. It's important for legal ethics, Do you guys have legal and ethics questions on your exam this semester? But you did last semester. Oh, whatever. Cool. Oh, and remember to explain exposure to the start. A lot of people forget about it. Little things like you need to be undressed from the waist up, but you can keep your bra on. Or I'll need to look at your legs. Are you okay with that? That kind of thing. Rather than being halfway through the exam going, right, top off. which would be weird. They'd be like, what? And you didn't tell me about this? Yeah, okay. Yeah, okay. So, vital signs. Blood pressure, heart rate, rest rate, temperature. Revise them. They're really important. Practice them when you can. You will be required to take your heart rate, the pulse in your cardio exam and know where the other pulses are. So people are pretty good at radial. Also, don't palpate the femoral one, guys. Please don't do that. But also things like popliteal, dorsalis pedis, being able to do both radials at the same time because you will have to do radial delay. They won't be a station on their own like they would be for your competency, but I've been a sim patient in a combo station. So it was BP and motivational interview together, and most people were fine, the students were fine at motivational interview, but they didn't get there because they had to do the blood pressure first, and they spent 8 minutes screwing around with the cuff. So most people got a borderline to a fail. 2 people passed that station. Yeah, so little things like that. Keep up to date with them, but they're not super important, so not too much detail. Cool. MSK General Overview. So it's the look, feel, move, measure, special test pattern. And then you do active before passive. Everyone knows why you do active first, right? Because if they can't move something and then you yoink it and you fracture their humerus, you're going to get sued. So tips and tricks, ask about their pain first and start away from the pain. So if they say, yeah, you're doing a shoulder thing, and then they say, oh, I'm really sore down the bottom, you'd start with the collarbone and you get there last. Really important to know your surface anatomy, know the normal range of movement, and be aware at the same time that some people are hyper flexible like me. So, and then know what's being tested in the special tests, and I'll go through that. But when you get a question in the exam, they won't say and then like the, what's the word for like someone's name? Eponyms, that's one. They won't say like, oh, do McMurray's. They'll be like, test for whatever McMurray's test for. So, the special tests for MSK. So, resisted abduction is supraspinatus. Resisted internal rotation is subscapularis. Resisted external rotation is infraspinatus. Hawkins test, this beautiful diagram here, is rotator cuff impingement. So is Neer's sign. Neer's sign is the backwards backstroke one. And then the empty can test is supraspinatus. So really important to know what they're testing for these special ones because in exam questions, they'll come up. For forearm, you guys know Phelan's and Tinels, so I won't go through that, but definitely the medial and lateral epicondylitis, so golfers and tennis elbow, the clenched wrist and then flex or extend resisted, know which side's which. I remember it with the 3 T's, so tennis is extend is lateral. That's how I remember that one. And then back and spine, a lot of people forget that back and spine is an MSK, but it is. So lumbar flexion is the Schober's test. And that's for ankylosing spondylitis, and it's the one where you've got to support their lower back and like move their legs and stuff. And then the nerve stretch test as well, the nerve root irritation, prolapse lumbar discs. Cool. Lower limb, Trendelenburg. I think people do this one pretty well, but sometimes people forget to do it in MSK. And then Thomas test with the flexflexion deformity. Patella tap is for large joint effusion. Bulgstein is for small joint effusion. McMurray's is medial and lateral, and Valgus varus stress test is medial and lateral collateral. And everyone knows the draw test is anterior ACL and PCL. I didn't include that. What the? Okay. Everyone knows those ones, so I didn't include that one there. Cool. PNS, general overview. There's a lot happening in PNS, and it can be really stressful. I know I failed that OSCE mid-year, so yep, keep it up to date. Inspection, tone, and then clonus and special tests for lower leg. Power, reflexes, coordination, sensation. So once again, ask about pain first. Know your myotomes, know your dermatomes, and know what's being tested. A lot of people forget things like clonus and the special test for lower leg. So you got to get slick at it. So upper limb, the finger nose, dysdiadochokinesia, and ballistic tracking, they're all cerebellar disease. And everyone knows cerebellum is balance and coordination, stuff like that. 2-point discrimination is in your sensory cortex, so this part of your brain here. And stereognosis is also your sensory cortex and association areas because it's not only feeling what it is, but recognizing what it is. You guys will learn all about this more in neuro in second year, but yeah. Lower limb, the pull test is for Parkinson's disease. I feel like you've done stuff on Parkinson's. Did you guys do like a digilab or something on it, or no? Someone told me you had. Anyway, Parkinson's disease is where they don't have as much control over their motor stuff. So when you pull them, they'll keep walking backwards. Romberg's test is proprioception, not cerebellum. So that's the one where you get them to stand there and shut their eyes and wait for them to start swaying and stuff like that. Ankylosing is upper motor neuron lesion. So yeah. You guys know the difference between upper motor and lower motor neuron lesions? So anything upper motor neuron is going to have enhanced reflex, enhanced tone. Lower motor neuron is your typical paralysis. Like if someone was quadriplegic, what would they present with? Just floppy, nothing's happening. Cool. Okay, CVS, I have inspection, pulses and JVP separate because people forget them. And then palpation, percussion, mentioned, don't do it, and auscultation. So the pulses are usually given in an OSCE, but you may have to take their pulse in the CCC because you've got longer time, revise how to do the pulses. Practice moving the patient beds because they reset them to flat after each time. And ask if the patient's comfortable, offer the pillow to support their back or rest their arms while you're doing stuff with the hands. Make sure when you're doing the JVP, you don't have them like upright because then you won't be able to do it properly and they'll be pretty uncomfortable. Cool. So this is your techniques. Mitral valve, you want to roll them over to this side and breathe out. Tricuspid, breathe in. Pulmonary valve, lean forward and breathe in. Aortic, breathe out, lean forward. Yeah, makes sense with this little diagram. And it's all about bringing the heart closest to the point we want it to bring it to, if that makes sense. So leaning forward for these upper ones here, which are going to be further back. You want to bring them forward, and mitral, you want to bring it to the side so you're going to be able to hear it. Easy. Cool. Now, motivational interviewing. So this structure is going to be like you guys have done those like Francesca Di Clementi kind of cycles and stuff like that. So it's going to be basically tackling it from that. So if it's something like smoking, you're going to want to start with, I thought we'd talk a bit about your smoking today. Is that okay? And then maybe perhaps tell me a bit more. So you'd say it was for this reason. Have you considered quitting, or why and why not? Would you consider quitting? If you're interested, there are things I can do. And then in this kind of motivational interviewing, you'll also get a point for like pretending to give them a brochure. It's literally a point. You'd be like, here's a brochure on quitting smoking. And they'll be like, tick. And then you'll, I'm not kidding, it's so stupid. Or if you guys have like a clip, you know, the clipboards where you write your stuff down beforehand, just grab one of the pieces of paper and fold it into a brochure and you're like, boing, 1 point. And then discuss elements like BASC, Francesca Di Clementi, SMART goals. It'll be given on the stem what one you'll have to go through. So know what they are because people forget. And I've got them here. So your SMART goals, I like action-oriented instead of achievable, because achievable kind of seems like, is it achievable? Not really. Give up then. Whereas like, what steps are you going to do to make this happen? And then we've got our cycle here. I like this one because it shows in the middle the upward spiral you learn from each relapse. So it might be worthwhile saying to the patient, you may fail the first time, but that's okay because you're going to learn from that first attempt. And when you try it next time, you're going to be stronger again. That makes sense to everyone. But I don't think this is very high yield for you guys, but I don't know, keep it in mind. Could come up, cool. Giving an explanation. Did you guys do this in first sem? Yeah, and it was your PBL topics? Was it PBL topics or was it something else? I know I had to do Down syndrome, so I think it was a PBL. Yeah. So this one can be pretty hard, and they'll actually tell you what you have to cover every time, but it's the information giving skills, aiding the recall and understanding, so getting them to repeat stuff back. Did you understand what I said? Can you repeat for me what I said? Understanding where they're coming from. So when you give the explanation, you need to know why do you want to know this information? How is this relevant? So the difference between 2 reasons why they might be taking the contraceptive pill. So it could be preventing pregnancy, or it could be for acne. So if they're taking it for acne and they're not sexually active because they're like 14 or something like that, if you start going, now, if you don't take the pill on this one day, you could get pregnant, and they're going to be like, this is not relevant to me. Vice versa. Yeah. So you need to understand what specific reason they're taking it for, or why you need to explain it to them. Yeah. Then your non-verbal communication skills. So being open and friendly and body language and being a nice person. I don't know. Seems pretty straightforward. And then obviously the knowledge of the condition or the concept. Don't make stuff up, because you'll actually lose more marks if you make stuff up than if you go, well, I actually don't know the answer to that question. I might get back to you later on that. But yeah. People make stuff up and then they're like, no, just no. So yeah, revise your ICL topics for that one. So yeah, I've done it pretty quickly because there's not a lot to cover and I didn't want to go through too much stuff, but I've got a couple of questions. These questions are real exam questions. I didn't make these up. And we might go through and explain why each of the answers is correct. So I'll give you a little time to read them and then we'll go through the answers. So, of the following, the least important part of doing a musculoskeletal exam is, have a read. C. A lot of people are saying C. And they'd be correct. Why is C not important? Because it's neuro. Yeah, cool. Because it's neuro. Yeah. Cool. So, hello? Sorry, guys. So, obviously, we're going to ask for consent every single time. Easy way to fail. You will fail if you don't do this. Inspect their body. Well, that's what you're doing. That's like the whole point of the exam. Feeling and palpating the area identified by the patient. Yeah. And comparing sites. Always, always compare sites. Cool. Because you might be like, oh, they don't have very much mobility, but then you check the other side and it's like, oh, that's just normal for them. They're just naturally like that. Cool. Next one. When moving a joint during normal exam, you should do the following except. I'm hearing C. Cool. You'd be right. Yeah, not at fracture sites. Please don't do that. Please don't do that. Yeah. So you would definitely do this at joint sites, definitely, because that would be checking for things like osteoarthritis or, joint problems there. Sorry, guys. Sorry. Yeah. Obviously, you're going to ask about pain. You obviously are going to do active movement first, and you do check range and stability. But trick question, you do still check crepitus at joints, but not at fracture sites. If they said, oh yeah, 6 weeks ago I fractured my wrist, you're not going to be wanting to like grind down on the wrist and make sure it's like, yeah. Cool. Examination of the patient's back. The GP finds rotation is markedly reduced. The pathology most likely will be found in the answering, I'm hearing B's, and they'd be right. So most of the rotation is in your thoracic spine. Most of your flexion and extension is in your lumbar spine. So really important to know that. If you said coccygeal spine, I'd hit you. I would smack you if you said coccygeal spine. That is stupid. Why is that even on there? I can't move it. I'm confused. Okay. Next one. You're on a placement with a GP and you're asked to take a cardiovascular risk factors history from Mrs. Compley. You would include questions about which of the following? Shout out answer? Answers? Anyone? B. B is correct. So everything else pretty much is respiratory. Yeah, you can get some like mad infections from pet birds. It's really crazy. Cool. Sorry guys, we only got a couple more, so I'll be quick. Dorsalis pedis pulse. This is a clinical skills question disguised as an anatomy question. So I'm hearing C, which is correct. Yeah. Know that one. And there's another pulse on the foot. Where is the other pulse on the foot? Posterior tibial. That's the one. Cool. 70-year-old heavy smoker with chronic shortness of breath has a sternal thrust and palpation of his chest. What is the most likely to produce this sign? You would know this if you went to Jamie's cardiophys lecture. Anyone? It's C. So, what is the most anterior central chamber of the heart? Right ventricle and right atrium. But the thrust is going to be powered by the ventricle because the ventricle is where all the muscle is. So this is, what is it? Probably like heart failure or COPD or something like that. So yeah, cool. And I think that's it. So thank you very much. If anyone has any other questions, email Nadita. Don't email me. Email Nadita. Don't email me.
Hi guys, probably start. How you guys doing? How was your 2-day smashing through, I guess, the whole of this semester as well as this year? How'd you guys find it? Good, yeah? So now I guess we'll try and wrap it up with pharmacology and see how you guys are going. Pharm is, I guess, pretty annoying, generally, just because you're kind of combining everything together. And you can go in so much depth in terms of, what to cover and stuff. So just to, I guess, look into it, there's so many things to cover. So we'll try and cover as much as we can. And yeah, I've got some questions for you guys as well. So we'll go through those as well. Yeah, so just wrap up, like 101.1 had a lot of mnemonics, like what red van syndrome, as well as, tons of other gray baby syndrome and a lot of other weird mnemonics. 1022 is a bit more different. You're using a bit more physiology, understanding, especially for cardiac drugs. But some areas do actually require some memorizations. So I think that's pretty important. Yeah, so in terms of structure, I've kind of like made each drug and have I've got 4 dot points or something, maybe about 3 or 4, depending on what kind of information I have. But usually the first dot point is the mechanism of action. And then you have the side effects, contraindications, what are some issues with the drug, and then clinical use. And some of these clinical use applications are a bit more important for next year as well and the year after. So it might be a bit weird and you might have not heard some of the conditions and stuff, but don't worry too much about that. Try and remember the ones that you know. And yeah, some other additional information, in terms of how you administer it and other things. Yeah, so in terms of pharm, this was, I think, in 2016, so 2 years ago, but we didn't get our mark distribution for our year. But yeah, it's about 13 marks. It's not as great, so in terms of, how much you have to learn compared to how many marks you actually get. So yeah, focus on anatomy and I guess clin skills and stuff. But yeah, pharmacology, just try as much as you can in terms of understanding everything. And you'll be fine, yeah. Cool, so we'll start off with general principles. So this is all the pharmacokinetics that you kind of went through. Yeah, so revision. You guys know pretty comfortable with these terms. So full agonist versus partial agonist. So full agonist is essentially a drug that actually can attain maximal activation. So whenever it interacts with an enzyme, it leads to full activation. So we kind of denote that as intrinsic activity equals to 1. Partial agonist is, even though it interacts with the enzyme, it doesn't release the maximal response that it can actually obtain. So intrinsic activity is less than 1. Competitive antagonist versus non-competitive antagonist. So for competitive antagonist, it actually competes against the agonist for the same site. So that's pretty different compared to non-competitive antagonist, where it kind of attacks a different site. And so that's really important, especially when we think of equilibrium. So if you've got like concentration of agonist and an antagonist, what's going to happen? And yeah, so regardless of those, the intrinsic activity is equal to 0. And yeah, you can also split up competitive antagonist into reversible and irreversible. So reversible is when it can kind of like detach itself, and then you have an agonist coming in. Whereas irreversible, it's not really the case. So for reversible, you can increase the concentration of the agonist, and that will lead to an opposite effect. So you'll get rid of that antagonist effect. Whereas for irreversible, that doesn't actually happen. Potency and efficacy, that's just a pretty important concept to kind of remember. So potency is essentially how much drug you actually have to give to get the effect. So if it's got high potency, that means you only need minimal amount of drug to actually get the effect. Whereas efficacy is essentially, even if you give the 100% amount, what's the actual maximum outcome? Yeah. Therapeutic index is pretty important to note. So that's essentially looking at the 50% mark of efficacy and the 50% mark of the toxic dose. So essentially, it's a fraction over the toxic over the effective dose. So if you have a larger therapeutic index, that's beneficial for you, because that means even if you screw up a little bit, you're not harming the patient. Whereas if you have a lower therapeutic index, then it's not going to be as great. Cool. Okay, so we're going to the things that you learned this semester. So in terms of absorption, we'll go through a few definitions first of all. So bioavailability, essentially the fraction of administered dose that reaches the blood system, that's unchanged, yeah? And there are many different administrations, but the ones I guess you should know is IV, IM, SC, and oral. And by definition, intravenous administration has 100% bioavailability because you just go straight into the bloodstream. Whereas intramuscular subcutaneous have a potentially low bioavailability. Bioequivalence is kind of like when you've got two formulations, and if you have a similar concentrations of both drugs, then you can say the drugs are bioequivalent. And I think it's pretty important, especially when you look into generic drugs and comparing those against branded drugs, for example. Oral administration, so we'll go into more depth in terms of oral administration. So it's really dependent on so many factors. So you've got like gastric content, intestinal mobility, GI flow, stomach acid, and a lot of interactions with food and other drugs. So that's really important. And depending on the drug, it can get absorbed in different areas. So if it's lipid soluble and if it's a weak acid, then it will be more easily absorbed in the stomach. Most generally, the small intestine is the primary site of absorption. And I guess you guys haven't learned this, but in terms of circulation, so whatever comes through the GIT system needs to pass through the liver to go to our circulation. And this is called the first pass effect. So what that means is that, and the liver is really important in terms of metabolism. So what that means is that if the drug or something is easily metabolized, that means it can inactivate the drug and it won't be as effective. So yeah, just remember what that means, first pass effect. So that means if you have drugs that are easily inactivated by the liver, then you have to find other forms of administration, such as parenteral, cannot pronounce that, IV, IM, SC. So those ones don't actually need to go through the liver, and so therefore more predictable. And yeah, so also know that there are other routes as well. So inhalations, you'll learn this more next year. Sublingual, especially for the nitrates. We'll cover that later onwards. Intrathecal, rectal, topical. Cool. Okay, so, oh, by the way, the ADME acronym stands for absorption, distribution, metabolism, and excretion is essentially the form, and I guess you guys should be comfortable with that. Cool, so distribution, essentially how is the drug actually distributed within the body, yeah? And that's really affected by, size, lipophility, so how lipophilic is it, and ionization as well. And I guess it's really important to note that the initial rate of distribution is really based on how much blood flow actually goes to the organs. So like your brain, your liver, kidney, tends to get a lot of blood flow. So in other words, drugs can easily go into those organs compared to muscle, skin, and fat. And so something interesting called drug redistribution actually happens for highly lipophilic drugs. So what happens there is when you first administer a highly lipophilic drug, I think thiopentol is a drug, but that's highly lipophilic. It first goes into the brain and liver and kidney. And then after that, it kind of immediately goes into fat and bone, sorry, fat in particular, because it's lipophilic. Definition, so yeah, the volume of distribution. So essentially, it's the theoretical volume of total body fluid required to contain all the drug at the same concentration as the plasma concentration. So what that means is that suppose if you have a drug that's really attached to the plasma, to the plasma, then you will need a lot of, not that much fluid. So you need to decrease the body fluid in order to increase the concentration of the drug outside of the blood system. Whereas if it's more, I guess, attached to body fluid rather than plasma, then it's the opposite. So you actually need more body fluid to decrease the concentration. Yeah. So I guess in essence, if you've got a lower VD, drugs are more bound to plasma proteins. If you've got a higher VD, drugs bind to tissue more easily. And this is very important, especially when you look at half-life and steady state concentrations. You guys are familiar with those? I'm pretty sure we covered those in semester 1. Yeah, semester 1. So if you've got a higher volume of distribution, that means you've got a longer half-life because they're more attached to the tissue. And this is very important in terms of thinking about steady state concentration. And yeah, it could be influenced by, so volume distribution can be influenced by many factors as well. And I guess the most important one here is edema and ascites. So if you have like heart failure, for example, that can actually affect the way drugs are distributed. Barriers, so just remember this, blood-brain barrier. So ionized polar drugs distribute poly to the CNS, so the brain and the brain stem, and placenta barrier, so for pregnant women and stuff. If you've got lipid-soluble drugs, they can cross the placenta more easily than polar drugs. Metabolism and excretion. So clearance is probably something you guys covered before. It's capacity for body to remove a drug. And it can be done in 2 ways. So it can be done either through metabolism, which is through the liver, or excretion, which is through the kidneys. Yeah, we've covered therapeutic index, so that's fine. But in terms of metabolism, just think of it as like you've got enzymes and then kind of like play around with the drugs to kind of transform it. So it's more easily excreted. So you're making it more water soluble, and this kind of comes back to chemistry. But so there's 2 phases. So phase 1 is anabolic. And this is where you're kind of like introducing a functional group. So whether it's a hydroxide group or some other group through oxidation, hydroxylation, making it more reactive. And some notable ones to remember is like cytochrome P450, which is probably something you guys heard of when you covered like the semester 1 drugs, so erythromycin, fluconazole. So if you've got those, if you've got erythromycin, it can actually screw up with cytochrome P450, and that can lead to reduced metabolism of other drugs. And phase 2 is catabolic, so it's more about conjugation. I guess you can think of this phase as making it less reactive. So phase 1 is making it more reactive such that phase 2 can actually occur. Does that kind of make sense? Yeah. And in terms of excretion, there's many ways in which drugs can be excreted. So it can be through the urine, so through the kidneys, feces, saliva, sweat, etc. Milk is very important, especially if you've got pregnant women, because it can affect the babies. And yeah, so some drugs can actually go through the bile, which is produced in the pancreas and pass into the intestine, and others can get reabsorbed through the intestinal blood circulation. And in terms of net renal excretion, just remember that there are 3 different methods. So you've got, or I guess 3 different processes. So filtration, secretion, reabsorption. Don't worry about those too much. It's more for next year when you go into renal and kidney stuff. Cool. So some questions. Have a look through that. I don't know how you guys do it. Do you guys want to shout out if you know the answer? Or A? Yeah. Yeah, so in this case, it's A. Yeah. Next question. The standard one. Yep, C. Very good. Okay, I think we've got some mixed answers here. The answer is C, because you've got edema, so that kind of screws up the distribution of the drug. Yeah. This one's a tricky one, so yeah. I heard some C's. Anyone have any other answers? C? Yep, so the answer is C in this case. Loading dose, maintenance dose. Do you want me to go through this, or you guys should be fine? Okay, go through it. Okay, so loading dose is essentially the dose that you want to add to the body to produce the steady state concentration. So in this case, F stands for the bioavailability in that equation. Do I have like a pointer? No pointer. Okay. VD stands for volume of distribution, and CP stands for the actual plasma concentration that you want. So what happens here is that if you keep the oral dosing rate constant, and if you increase F, then what happens is, because you're keeping the left-hand side constant, the top section must also increase as well. And since volume distribution doesn't change, it's steady state plasma concentration that increases. That's one way of looking at it. Another way of looking at it is if you're increasing the availability of the actual drug, then obviously that kind of increases the plasma concentration as well as equilibrium in terms of what's the steady state. Yeah. And maintenance dose is more like sections. So if you want to continuously maintain a particular dose, that's dependent on CL, which is clearance, and T, which is like the timing in terms of when you actually put in the doses. Any questions? Any answers? Sorry. Yep. D, did someone say D? Yep, that should be a good question. Okay, next one. What do you guys think? Yep, B here. Cool. All right, so DMARDs. Yeah, so this is all about rheumatoid arthritis and gout. There's only a few meds, I think it's about 9 or so that you need to know. So yeah, all right, let's go into it. So first of all, basic 5 arms of inflammation, just a few things to know. So if you've got too many white blood cells, that leads to the 5 main symptoms. I kind of think of it as like, you go through an OSCE or something, you think of, you've got redness, swelling, because of swelling or redness, it looks a bit hot, and the pain, and because of the pain, you don't have, you've got loss of function as well. And so the goal is, to reduce the immune response. So drugs, yes, looks pretty confronting, but we'll see how we can go. Methotrexate, so that's actually a cancer drug that you guys covered in semester 1. It's also used for rheumatoid arthritis. It's a folate acid analog that competitively inhibits dihydrofolate reductase, which is the thing that actually produces folic acid. And so that actually ends up leading to decreased DNA synthesis. It also acts to inhibit the function of T and B cells. And so side effects, myelosuppression, so that's bone marrow suppression, hepatotoxicity, mucositis, and pulmonary fibrosis. And in terms of conditions and stuff, so the main ones you need to know is rheumatoid arthritis and cancer. And the reason why, it's also highly related to pregnancy as well, because if you're screwing up the folic acid, that also screws up the development of the baby, and that can also lead to medical abortion. And the rest, so psoriasis, graft rejection, all immunological responses. IBD stands for inflammatory bowel disease that you'll cover next year. Leflunomide, so that prevents pyrimidine synthesis by reversibly inhibiting dihydroorate dehydrogenase. So I guess just remember dihydroorate dehydrogenase, and it can also suppress T cell proliferation. Same thing here, rheumatoid arthritis and psoriasis, but instead the main side effects you need to know is diarrhea and hypertension, hepatotoxicity. Azathioprine, so that's a purine analog, and that decreases de novo purine synthesis. So de novo purine synthesis is kind of like creating DNA monomers through other products. So usually kind of reuse DNA, but if you want to create it, that's de novo purine synthesis. And so by reducing that, then you've got less DNA synthesis. Suppresses T cell activity, much more than B cell. And the most important thing here is it's metabolized by xanthine oxidase. And xanthine oxidase is an important thing that actually contributes to gout as well. So you can't really put in azathioprine with gout drugs. And similar side effects, and rheumatoid arthritis as well as other immunological pathologies. Cyclosporine, so that's calcineurin inhibitor, binds to cyclophilin, blocks T cell activation by preventing IL-2 transcription. And I think the most important one here is gingival hyperplasia as well as hirsutism. I think it's the only drug that does that. Not quite sure why, but yeah. And you've got conditions like rheumatoid arthritis and psoriasis. Infliximab, so that's a monoclonal antibody. Usually, if you find a drug that finishes off with MAB, that's a monoclonal antibody. And the purposes of monoclonal antibodies is that it targets TNF-A, which is important because it mediates immune responses. So it also leads to immunosuppression, and the problem is immunosuppression, and it can also lead to like reactivation of infections like TB and stuff. This one's given intravenously. And yeah, pretty important for rheumatoid arthritis. Triple therapy, I guess just remember these three. I got this from last year's lecture, so I wasn't quite sure why he put it in, but I just put it in just because. And rituximab, which is the last one, which is a CD20 inhibitor. And side effects for this is like infusion reactions, cardiac arrest, tumor lysis syndrome. So this is a very serious drug, and I guess it's not used as much, except for severe cases. Gout. So for gout, just remember the two main drugs, which is, the three, but the main two drugs are chronic, the one that treats chronic gout and the one that treats acute gout. So the way I think of it is like, chronic gout kind of goes through the mechanisms and kind of destroys or kind of inhibits the creation of urate, whereas colchicine kind of reduces inflammation, so it's more acute, it's more fast-paced. So allopurinol, it's a competitive inhibitor of xanthine oxidase. So if I go to the next page, here you've got a nice diagram. So the outcome is you do create uric acid. And so allopurinol, and that's some other drug, they inhibit xanthine oxidase to inhibit the creation of urate. GI disturbances, dermatitis, that's kind of like the main ones. So you can use it for gouts, but as well as lymphoma and leukemia. For acute gout, that's inhibiting microtubules. So if you're inhibiting microtubules, you're impairing like the neutrophil chemotaxis and therefore degranulation. So that kind of reduces the immunological response. And for this one, it's very similar to NSAIDs in terms of GI symptoms. So you get a lot of GI symptoms for that. And finally, for probenecid, so that's, if you look at here, so that section there is actually the kidney, and it inhibits the uric acid to go back into the bloodstream. So it kind of stays in the kidney, it just gets out of the system. So as you can imagine, because it's kind of like in the kidneys, that can lead to uric acid calculi, which is kind of like kidney stones. So it can get stuck if it's like big masses of uric acid. Cool. All right. Questions? Okay. Does that make sense? Yep, we've gone through that. So in this case, it's it prevents DNA synthesis, and that leads to acting as a period analog, and screws up that whole process. C? Yep. Oh, wait, what? D. Yeah. So going back to, so it's colchicine in this case. All right. Okay. Moving on. Hope you appreciate the quote, but okay. So autonomic nervous system drugs. In terms of these drugs, you don't really need to know the names of it as much. It's more just like how the actual process happens. So don't worry too much about the names, and I've tried to implement, and I think most questions they will say, it's beta agonist or antagonist or something like that. So in terms of, it either affects the parasympathetic system or the sympathetic system. You guys have gone through this, right? Have you gone through this, or? Yep. Did someone go through this beforehand? I guess they did with the other ones. So, but generally it's, just remember the weird name. So mydriasis versus meiosis. So meiosis is constriction of pupil, whereas mydriasis is the dilation of pupil. But it's pretty basic stuff. So these are the main pathways that you have to kind of like remember. So you've got the sympathetic and parasympathetic pathway. The preganglionic fiber always has a nicotinic receptor, regardless if it's sympathetic or parasympathetic, and you always have acetylcholine. And the most important one in this case is sympathetic. You've got the alpha and the beta receptors, and usually it's norepinephrine, but sometimes you can have acetylcholine and sweat glands. This is a question that sometimes comes up, so make sure you remember that. For parasympathetic, the postganglionic fibers, you've got muscarinic receptors, and in this case, it's acetylcholine. That's the neurotransmitter. Adrenal glands, so this is like the kind of the glands on top of the kidneys. There is no, I guess, two fibers, so there's only one fiber. And that just releases acetylcholine to a nicotinic receptor. And then as a result, you get epinephrine and norepinephrine. And finally, here you've got the somatic fibers, which is just the basic ones. Cool. So, yeah, I can hear some groans. This is pretty annoying. But just remember M1 to M3. I think that's the main one that they usually ask. But the way I like to remember is just M1 is gastric and salivary glands, CNS. M2 is the heart, and M3 is everything else. So for M1, you've got acid secretion, salivation, as well as some central nervous system action. And within the heart, because it's parasympathetic, decreases contractility of the atria and decreases heart rate. And for smooth muscle, so everything else can be, can bladder contraction to meiosis, accommodation, bronchoconstriction. Yeah, so just remember what those words mean. And M4, M5 is kind of like unknown, but it's related to Parkinson's or Alzheimer's. Cool. And sympathetic receptors. The way I like to think of this is like A1 and B2. A1 and B2 do completely opposite actions. So A1, alpha 1, does vasoconstriction, whereas beta 2 does vasodilation. That doesn't really make sense, but it really depends on where you are. Because in terms of sympathetic, it's you want to redistribute the blood such that it goes to, let's say, skeletal muscles and minimize the blood going to the GIT system. And so the receptors are kind of like in different areas to try and accommodate that. Yeah, so for alpha 1, just remember it's vasoconstriction and mydriasis. That's an important one there. Alpha 2, just think of it as like a negative feedback system. So it's in the presynaptic nerve terminals, what the hell is that? And it decreases the sympathetic outflow. So if you have like kind of a sympathetic outflow, it goes back and leads to some kind of feedback system. Beta 1 and beta 2, so you can think of beta 1 as heart. So you've got one heart and you've got two lungs, right? So beta 1 is for the heart and beta 2 is for the lungs. So beta 1 leads to increased heart rate, contractility, increased renin secretion, as well as lipolysis. Whereas for beta 2, as we've mentioned, it was vasodilation compared to vasoconstriction and bronchodilation. So this is very important, especially for asthmatic drugs when we look, and you'll look into that next year. And yeah, and another one is also increased aqueous humor production, which is like pretty important as well. Beta 3 is just GI, smooth muscle, adipose cells. It's not as important, but yeah, that's kind of like the way to do it. So just remember the top 4, and if they ever ask you a 5th question, yeah, good luck. Sorry, the 5th one. So important notes for alpha receptors. That's the general trend. So it reacts more easily to norepinephrine. So norepinephrine is the same thing as noradrenaline, yeah? So epinephrine, adrenaline, you can kind of like resubstitute those words. And epinephrine going to isoproterenol. Whereas for beta receptors, it's the other way around. For epinephrine, generally beta, it works better for beta compared to alpha. So what does that mean? If it works better for beta compared to alpha, would that lead to vasoconstriction or vasodilation? vasodilation, yeah, because beta-2 is the one that leads to vasodilation. But this is very important, especially for surgeries and stuff. So if you have higher doses, so let's say if you just inject epinephrine into your body, then alpha actually predominates. So that leads to vasoconstriction. And this pathway is something interesting that I found. Essentially, just shows the pathways that each receptor takes to lead to the effect. So just remember that each has a G protein, and that leads to a cascade of reactions that leads to either increase in calcium that leads to smooth muscle construction, or some other smooth muscle reaction through the protein kinases. And M3 can also exist in endothelial cells, so within the blood cells, and it can promote the release of nitrogen oxide, which is very important because it diffuses to smooth muscle and leads to vasodilation. So core drugs, so pyridostigmine, anti-cholinesterase inhibitor. So anti-cholinesterase, what it does is that it I guess kills off the ACH within the after it gets released, and so it inhibits that enzyme. So as a result, you've got more ACH within the I guess released, and so that increases neurotransmission. And as a result of that, you've got more parasympathetic activity, which can lead to bronchoconstriction and can lead to exacerbation of COPD, which is a lung disease, as well as asthma and peptic ulcers. Most important clinical use is myasthenia gravis. So yeah, and it's long-acting in this case, and it's used for that condition. Atropine is a muscarinic antagonist. So in this case, it inhibits the muscarinic effect or inhibits the parasympathetic effect, which leads to more sympathetic activity. And as a result of that, you can lead to mydriasis, which can further lead to acute angle closure, glaucoma, and other forms. Yep. Cholinesterase. Oh, that's true. Yeah, I did the other way around. Yeah, I'll double check that, but I think you're right. It's probably anti-cholinesterase or cholinesterase inhibitor. That makes a bit more sense. Finally, yeah. So for atropine, just remember it's used for eye exams, so especially when you want to produce mydriasis, and it can also help to treat organophosphate poisoning as well. So organophosphate poisoning, you've got like organic compounds that act as anti-cholinesterases, and as a result of that, you want to kind of like do the opposite effect, and so that increases the sympathetic activity. So they're essentially the opposites, you know. And yeah, the main parasympathetic effects and sympathetic effects are here. Good acronym to remember is dumbbells. So you've got, yeah, so just remember that. And sympathetic effects is, yeah, that was a very interesting kind of like way to remember it, but I guess you can just think of the opposite. Yeah, just remember the parasympathetic and sympathetic effects. And yeah, you can kind of use logic for these types of questions, but yeah. Cool. So this wasn't part of the thing, but I think you guys might have covered this. I hear C. Yep, answer C. Good job, guys. This one, just think of the symptoms and think of the drug that you've done. I know I've put in like drugs that you haven't heard of before. So the answer here is C. I guess the key word here is insecticide, so it's organophosphate poisoning, and so you need to use atropine for it. Any ideas, guys? A? Yeah. So yeah, I guess the idea here is Day-2 is very selective. To be honest, I think in real life, I think they probably use hypertropium because for some reason it's got less cardiac effects. But yeah, I reckon just use your common sense and it'll make more sense. We'll probably do this question and we'll finish off. I don't know if I have another question after this, but. What do you guys think? D? Yeah, so the answer is D in this case. So yeah, the idea here is that if you have a lot of epinephrine, that can lead to vasoconstriction compared to vasodilation. All right, we'll move on. Cool. Okay, so next part is, yeah, this whole section. I don't know how many lectures you had on this, but yeah, this one's pretty self-explanatory, but yeah, let's go through this. We'll see how we can go. So the main part that you need to remember is pain management. So how painful the patient, how much pain the patient is in. So depending on that, you can decide what medications to actually give them. So yeah, you can just go through that list. And NSAIDs, as you guys know, is non-steroidal anti-inflammatory drugs. Yeah. Cool. So this is we're going through the isocoinoids pathway here, just so you guys have an idea of it, and where the drugs are. It kind of affects this pathway. So the most important thing is COX-1 and COX-2. That's probably what you guys have heard. And so ignore the left half, because the left half's kind of slightly different, and you don't need to know that for the exam. It's just this right half. And the idea is that you've got a whole pathway going from membrane phospholipids to phospholipase, A2, and that leads to the production of arachidonic acid. And through COX-1 and COX-2, that leads to prostacyclins and prostaglandins being produced. And some drugs only attack COX-1, some drugs only attack COX-2. And they kind of like have different reasonings for that. But prostacyclins and prostaglandins lead to a lot of inflammatory problems as well as pain, and that's why it's really important. So this is kind of like the main difference between COX-1 and COX-2. So COX-1 is a bit more physiological, so it happens a bit more naturally, whereas COX-2 is more pathological. So you have like tissue damage. From what I remember, I think it's stored in some kind of tissue. I don't know. It's stored in some kind of cell, and then if that cell is damaged, then it gets released. So yeah, so it leads to like inflammation and all that kind of stuff. So we definitely want to try and target COX-2 compared to COX-1, right? Because COX-2 is the one that actually leads to inflammation. The only problem is a lot of patients have a lot of heart problems and stuff, and COX-2 can be very bad for the heart. And yeah, so the main difference is COX-1 is bad for the stomach and COX-2 is bad for the heart, but they're both bad for the kidneys. So if you know, you've got actually we'll go through that and it'll make a bit more sense. But essentially, you've got prostacyclins and prostaglandins that kind of screw up the circulatory system of the kidney, and that leads to kidney failure. But yeah, just remember which one's more important here. Cool. So pain and mechanisms. So first of all, pain transmission is usually through afferent nociceptive neurons, and fast pain is through A delta fibers, and slow pain is through C fibers. And so this is going to be very important, especially when we look into local anesthetics. NSAIDs. So as we've looked into like the whole pathway, what prostaglandins actually do is they open sodium channels, and that sensitizes pain both peripherally and centrally, and kind of leads to the enhancement of pain. And so COX actually blocks these prostaglandins and helps reduce the pain. Opioids, just remember the three main receptors. So you've got mu, delta, and kappa. Mu is the most important one, and it's usually the one that most drugs want to target. Yeah, you kind of need to think about how an actual potential works, but if you close the calcium channels on the first order neurons, that doesn't actually, so calcium channels help to promote the release of neurotransmitters. So if you're closing calcium channels, then the neuron can't release neurotransmitters, and so the actual potential can't go through. And if you open the potassium channel on the second order neuron, that leads to hyperpolarization of the second neuron. And so that means that the transmission can't actually occur. And opioids can also inhibit acetylcholine, norepinephrine, and other substances as well. In terms of local anesthetics, it blocks sodium channels, so by binding to specific receptors, and so that doesn't lead to action potentials. And in this case, small diameter neurons are more effective compared to large diameters, and myelinated, because I guess it's more quicker, is better than unmyelinated. Cool. So in terms of NSAIDs, the main ones that you need to know is over there. So paracetamol is centrally acting. So in other words, it's really good for headaches. And it's non-selective, so it's COX-1 and 2. And if you have an overdose, just remember this word, and acetylcysteine, which is the treatment. Yeah, and mainly it's only for pain and not anti-inflammatory. Ibuprofen is also non-selective. And in terms of problems, it can lead to sodium retention and other GI disturbances. And the main reason why is because it focuses more on COX-1. So, so as a result of that, it can destroy like the linings of the stomach, and as well as renal ischemia. So that's renal failure, because irregardless of the COX-1 or COX-2, it can be bad for the kidneys. Aspirin irreversibly inhibits COX-1 at low dose, and it's non-selective at high dose. And this is very important because it leads to different outcomes. So at low dose, it's more as like kind of like an anticoagulant, whereas at high dose, it's more anti-inflammatory. And the main side effect is salicylism, which is aspirin overdose. And the only one that you need to remember, which is selective for COX-2, is, I think I'm not quite sure which one you guys need to know, but I'm pretty sure selects COX-SIB. Just kind of remember it selects COX-2. Yeah, and yeah, so in terms of effects, thrombosis, self-allergy, and as well as heart problems as well, because COX-2 is bad for heart. Cool. And in terms of salicylism, these are the main symptoms that you get. So you have gastric ulceration, GI bleeding, tinnitus, and deafness. So it affects the ears. as well as the kidneys, so it leads to renal failure. Because of hyperventilation, you actually lead to, I guess, problems. Don't worry about respiratory alkalosis and stuff. It's essentially problems in the acid-base thing, and your body becomes too alkalytic. And so you want treatment for salicylism is actually trying to remove the alkaline content, and that's through forced alkaline diuresis, as well as activated charcoal. And Reye syndrome is something that's actually pretty, was common, and happened when children had like viral infections. And if you treat it with them with aspirin, it leads to this kind of syndrome, which is very similar to salicylism. So yeah, so just be careful of giving aspirin to children. Cool, opioids. So yeah, just remember that there is different levels in terms of how strong the opioids can be. So tramadol is a very weak opioid agonist and is good for chronic pain. Codeine is a more mu-receptor weak opioid, and contraindication in this case is don't use it for breastfeeding women. Morphine is a very strong opioid, and naloxone is an antagonist, so it's the opposite. It's used for opioid overdose. And that can lead to hyperalgesia. Side effects of opioids, so just remember nausea and vomiting, respiratory depression, constipation, meiosis, as well as addiction. It's pretty common. When you take off opioids, you can either get serotonin syndrome or withdrawal symptoms as well. Cool, and these are some other drugs that you need to know as well. So pethidine, medium strength opioid, methadone, and loperamide. Loperamide is used for GIT because it's not actually absorbed that well to the system. Yeah, cool. And finally, for local anesthetics, so we've gone through the pathophys already, but in terms of order of loss, you always lose pain, first of all, leading to temperature, touch, and pressure. So yeah, I don't know, like I had my teeth removed, and I remember I was still able to feel pressure and touch, but pain and temperature is definitely gone. And you can break anesthetics up into two different sections, so esters and amides. So for esters, they don't have an I in the name. Oh, actually, it should be the other way around. Is it the other way around? Let me check this, because I think it's the other way around, isn't it?
Yeah.
Yeah, I don't know why I put it like that. But anyways, I'll fix it up and I'll post it back later. So it should be have an I in the name before the cane, and amide doesn't have an I in the name before the cane. And yeah, so it's broken down in the liver, longer half-life, and I think you just need to remember that lignocaine can cause corneal damage. And amides is different to esters in the sense that it's got shorter half-life and it's broken down in the plasma. So just notice the difference between the two. Cool. Steroids. So they're synthesized in the adrenal cortex from like cholesterol precursors, and you can divide them up mainly into mineralocorticoids and glucocorticoids. Glucocorticoids have an anti-inflammatory activity at high concentrations. And yeah, so it's important to know that glucocorticoids actually have a negative feedback loop. So if you have a lot of glucocorticoids, then hormones that produce glucocorticoids get reduced. And this is very important because if you, let's say, take off glucocorticoid, then that can lead to withdrawal symptoms because you've got less of the hormones to produce glucocorticoids. And yeah, so it's important for considering for these adverse effects. And going back to that pathway, notice how you've got glucocorticoids and inhibits arachidonic acid. So that's the main thing there that you have to, phospholipase. So it inhibits phospholipase, and that leads to decreased arachidonic acid. Cool. And when you use these steroids, usually you use it when someone has like minimal, not enough steroids, I guess. So glucocorticoids and mineralocorticoids, you've got less of those, and you want to produce more of those, then you just add in these steroids. And the most important one in this case is Addison's disease. And you can also have issues in terms of inflammation and allergies as well. Yeah, so in terms of the main glucocorticoids, prednisolone, the main side effect is it can raise blood sugar levels in diabetics. Dexamethasone is the most potent anti-inflammatory. Fluticasone is the most important one. Is it's an inhaled corticosteroid, so you use it for patients with asthma. And yeah, and so the main side effects that you can get is Cushing's syndrome, which is due to the excess administration of glucocorticoids. And as I mentioned before, the withdrawal syndrome, which is due to the negative feedback loop. And so the body kind of stops producing endogenous steroids as a result of that. So this is what you get in terms of Cushing's syndrome. Yeah, so these are all symptoms of just having way too much glucocorticoid or steroids, I guess. And so it can lead to fluid retention, moon phases, which is a pretty common prevalent symptom, and osteoporosis, as well as other things. Cool. Okay, question. Any thoughts? D? Yep, answers D in this case. Makes sense? Yep, so mu receptor is the most potent of all the opioid receptors. And yeah, so that's pretty important. Next one. E? Yep, answers E in this case. E? Very good. Makes sense, yeah. So in this case, loperamide isn't absorbed properly, so it doesn't lead to the opioid things that happen with the other drugs. A? Yep. Makes sense in this case. So ibuprofen is one of those ones that inhibits COX-1 and COX-2. And yeah, regardless if it inhibits either of them, it's bad for the kidneys. Yeah. Okay, we are running out of time. We'll do this one quickly and then we'll go into cardiac drugs. Yep, in this case, just remember that low dose versus high dose. Oh, and that's a nice quote that I found. So cardiac drugs is all about understanding the physiology. So once you understand the physiology, then you'll be fine in terms of thinking about the mechanisms and thinking about when you actually need to use them. So yeah, so treatment based on physiology. So let's say if you have hypertension, you want to reduce the blood volume and the total body water, or reduce the total peripheral resistance. So either of those can actually minimize and reduce the blood pressure. Angina. So the problem about angina is that heart muscles actually don't get enough oxygen. So you can either increase the cardiac output, which helps to redistribute the oxygen, or decrease the cardiac oxygen demand, which can be done through particular drugs. Heart failure, so when the cardiac output is not enough for oxygen demand, you can increase the cardiac output, reduce total body fluid, or prevent tachycardia in this case because of the reflex tachycardia that can happen. And arrhythmias, so you want to decrease the conductivity or increase the contractility. Arrhythmia is a bit more complicated, and we'll go through the medications and I'll kind of make it a bit more sense. So drugs that act on the renin-angiotensin system. So the main two ones are ACE inhibitors and angiotensin receptor blockers. So ACE stands for angiotensin converting enzyme, and ACE inhibitors, what they do is they inhibit that enzyme, which you can go to that diagram here. So it inhibits that enzyme that leads to a decrease in angiotensin 2. And as a result of that, it decreases arterial resistance, which therefore decreases the blood pressure. It can also decrease GFR. So GFR is glomerular filtration rate. And the idea here is that it minimizes the flow of blood into the kidneys or into the nephrons, and that somehow leads to more sodium going out into the urine. And a main thing that you have to remember is that sodium and water are highly interconnected. So you've got sodium going into one section, and water also follows as well. So you've got more sodium inside the urine, that leads to more water being excreted out. So that decreases the amounts of blood within the body, and increased renin due to loss of negative feedback as well because of the loss of angiotensin 2. Important side effect is, so inhibition of ACE inhibits angiotensin converting enzymes can prevent the inactivation of bradykinin. And I don't know if you guys covered this, but bradykinin actually leads to coughing. So you've got increased bradykinin that leads to increased cough. And so that's the main difference between ACE inhibitors and ARBs. So for ACE inhibitors, that that leads to that bradykinin thing. Whereas for ARBs, it actually doesn't happen because of it just blocks the receptor rather than blocking ACE inhibitors. So the bradykinin procedure is still the same and quite normal. So you don't have the cough. So other side effects, just remember this acronym. So cough, angioedema. It's also teratogenic. It's also not good for pregnancy. Increased creatinine, hyperkalemia, which is bad for the heart. Hypotension. And another one that comes up sometimes, don't use if patients have bilateral renal artery stenosis. And so whenever you've got a lot of fluid within the blood system or within the body, it's a good drug to use. Either of these. So hypertension or heart failure, good ones to use for these conditions. Proteinuria and diabetic nephropathy is something you'll cover later onwards. And I think in one of the lectures, you guys probably covered something regarding heart remodeling. Heart remodeling is a major issue. So ACE inhibitors in particular actually prevents heart remodeling as a result of chronic hypertension. ARBs is very similar to ACE inhibitors. The only difference is just the cough. Just remember the cough, and you'll be fine, as well as how it's actually done. Beta blockers. So decreasing the sinoatrial, atrioventricular nodal activity by decreasing CAMP and calcium currents. We kind of covered this in the autonomic nervous system thing. So if you look at the pathways, it's essentially the same pathway. Which one is this in this case? Which one's more important, beta 1 or beta 2? Beta 1, yeah, because it's for the heart. And inhibits renin release. So beta blockers is very important. Somehow inhibits renin release, and that leads to decreased angiotensin and therefore increased fluid excretion. In terms of side effects, so because beta blockers aren't usually, distinguished as much, it can actually affect the lungs as well. So it can lead to bronchoconstriction, can also mask hypoglycemia, and bradycardia because you're decreasing the heart rate. And as a result of that, you can also get claudication and exercise intolerance. And when you use it for angina, stable heart failure. Do you know why it's stable heart failure, not normal heart failure? It kind of makes sense why. So in this case, because the main thing in heart failure is you want to get rid of the fluid, right? And by inhibiting renin release, you can lead to increased fluid excretion, but you're also decreasing the heart rate. And as a result of that, the heart's pumping a bit more slower, and that can lead to problems. So if you've got unstable heart failure, you probably want to use other drugs, and beta blockers are a bit more effective for stable heart failure. And yeah, because of bronchoconstriction, don't use it for asthmatics, diabetics as well, because of the hypoglycemia issue, and people who are taking calcium channel blockers as well. Because, yeah, so just remember B and C, never use them together because they just make the cardiac output too low. Calcium channel blockers, how are we going with time? We've got 10 minutes, okay. We can kind of cover, I don't think we're able to do the questions, but you guys can probably do the questions by yourself. So we'll just go through the different conditions, different drugs. Yeah, so calcium channel blockers blocks calcium channels, and that leads to decreased contractility as well as AV, conduction velocity. It also leads to increased effective refractory period, and that could also increase the PI interval as well. Also leads to vasodilation. What's the most important thing here is that there are actually two different types of calcium channel blockers. So there's that long name, dihydropyridine or non-dihydropyridine. Dihydropyridine acts on everything except for the heart. So it acts on vascular smooth muscle. And the main two ones I need to know is amlodipine and nifedipine. And so it leads to vasodilation of those vessels. And so you can treat angina because more blood flow, and you can treat hypertension as well. Raynaud's phenomenon is interesting phenomenon where blood flow doesn't actually go to particular areas of the body. And so by using this drug, because of vasodilation, you can actually treat this condition. Non-dihydropyridine acts on the heart. So the main two ones in this case is verapamil. I think that one comes up quite a bit, and diltiazem. And in this case, you use it for hypertension, angina, AF, and flutter. AF is atrial fibrillation. So our bench is a really good way of thinking, remembering the side effects. So first of all, you get reflex tach. So this is only for the vasoselective ones, for the dihydropyridine. But because it vasodilates, the heart needs to actually pump more quickly in order to overcome that. So that leads to reflex tachycardia. And for the non-dihydropyridine drugs, you have like bradycardia, edema, nausea, constipation, and yeah, these are a bit more vague, but constipation, headache, erythema, and dizziness. Diuretics, yes, this is going to be killer, yeah. To be honest, like pharmacologists, you have to just like cop it. Yeah, it's just kind of like, yeah, pretty heavy. But yeah, anyways, loop diuretics acts within the loop of Henle, which is like within the nephron. So this is a picture of the nephron, and this is the loop of Henle. And so what loop diuretics do is they block a particular transporter here. And as a result of that, it prevents the concentration of urine in this section. And as a result of that, somehow in this last section, you get more aldosterone working and other I guess receptors working here, and that leads to more fluid being excreted by the kidney. So then that actually is a really good treatment for heart failure as well as hypertension. And ODANG was a good acronym to remember the side effects of loop diuretics. Just remember that loop diuretics and thiazide diuretics lead to hypokalemia, but because potassium-sparing diuretics, they spare potassium, that leads to hyperkalemia. I think that's the main difference I need to know here. And in terms of thiazide diuretics. So if you look at that thing there, it's that section over there that inhibits. And so it's the same thing here. So notice how in all of these cases, you've got sodium coming out, and that leads to water following that as well. And this is a good acronym to remember the side effects of thiazide diuretics. So hypergluc, so everything's hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. We'll go through nitrates. So in this case, just remember vasodilates by increasing nitrogen oxide and vascular smooth muscle, and that leads to increased CGMP and smooth muscle relaxation. And so this is very important for cases like angina and acute coronary syndrome. Also important thing is it dilates veins more so than arteries. And so as a result of that, you're actually decreasing preload. And similar to calcium channel blockers, you can actually get reflex tachycardia, hypotension because of the dilation, flushing, and headaches. And don't use it with Viagra as well. That's a interesting thing that always comes up sometimes. Cool. Antiarrhythmics. Okay, so we'll go through this really quickly because we don't have much time. But just remember that there are 4 different classes. The first class can be broken up into 3 different sections. And each of these affects the action potential in different ways. So class 1A lengthens it, class 1B shortens it, and class 1C does half of half. And as a result of that, you can use it for different conditions, different arrhythmias. Class 1B is very important for post-MI. So if you've got like ventricular arrhythmias after a myocardial infarction, you can use class 1B drugs. These are the other classes. So class 2 are beta blockers, class 3 are potassium channel blockers, and class 4 are calcium channel blockers. And the idea here is that beta blockers slow down that. So the top one and the bottom one highlight the pacemaker cell action potential. And so it essentially just slows that pathway down for both class 2 and class 4. Whereas for class 3, you're just prolonging the repolarization of the action potential. Yeah, so this is a good summary of that. Finally, do we have a few more? No, we have a few more. Okay. Yeah, you guys can leave whenever you want to. It's I know it's kind of. I'll try and finish this off so you guys have the information. But so digoxin is another arrhythmic that you need to remember. The pathways that it inhibits sodium potassium ATPase, which indirectly inhibits sodium calcium exchange. And that increases intracellular calcium. That leads to positive inotropy, so it increases the contractility. And it can also stimulate the vagus nerve, so the parasympathetic activity as well. For adenosine, it's very short acting, so just remember that. It acts like it takes about 15 seconds for it to actually happen, and you give it intravenously. And so what it does is it increases potassium out of the cell, hyperpolarizing the cell, and decreasing intracellular calcium. And as a result of you decreasing the AV node conduction. Yeah. Okay, lipid lowering drugs. Just remember statins, fibrates, and this other drug is ezetimibe. I'll just explain like the pathway here because this is a really nice picture. But essentially, you've got statins on the left here, and they stop that enzyme, and as a result of that, you're not producing cholesterol. Yeah. So that's the first one, which is statin. So anything that finishes off the statin is this HMG, whatever. And yeah, and these are a few contraindications. Just remember the weird ones. I cannot drink grapefruit juice. Yeah, sometimes comes up. And you use it for hypercholesterolemia because it inhibits that pathway. For fibrates, it upregulates the LPL over there, and that leads to triglycerides being cleared properly. So that's why it's really good for hypertriglyceridemia. And ezetimibe is, where is it? Oh yeah, over there on the right. So it actually stops the process of cholesterol going into the blood system. So if you're inhibiting that, then chylomicrons can't actually receive the cholesterol and doesn't lead to that whole process. Yeah, cool. Just finishing off with like important drug interactions. So don't combine things that have the same effect or similar effects. So we've mentioned beta blockers with calcium channel blockers, but beta blockers with ACE inhibitors, they both inhibit renin, so that can be a negative effect. Loop diuretics and thiazides, they both affect the kidney, and that can lead to hyperkalemia. Remember, loop diuretics and thiazides lead to hyperkalemia, whereas the potassium sparing lead to hyperkalemia. Digoxin diuretics, less clearance of digoxin leads to toxicity. ACE inhibitors and spironolactone, risk of hyperkalemia. And ACE inhibitors and ARBs literally do the same thing, and that can lead to renal failure. And this is just another one that probably worthwhile remembering. So don't use these three drugs together: NSAIDs, diuretics, or ACE inhibitors, ARBs. The reason why is that they screw up the blood circulation to the kidney, and it damages the kidney. So just don't do that. But that's pretty much it. Cool. All right. Thank you. Close this.
Yep, I'll just stop all that.
I should probably delete this. This will be worth.
That's fine.
That's fine. Okay, go ahead.
Guys, thank you all for coming. Hope you learned something and hope you found it helpful. It's been great here getting to know all of you, and best of luck for your exams. I'm sure all of you are going to ace it. So.